Okay, welcome everyone to Methodist Children's Hospital's first perinatal cardiology grand rounds. Today we will talk about identifying fetal heart defects on the anatomy ultrasound exam. So the objectives today are to review the standard cardiac ultrasound imaging planes. We'll analyze the different congenital heart disease lesions that can be identified in the four-chamber, the outflow tract, and the three-vessel view. We'll also discuss the anatomy and the key fetal imaging features of these congenital heart disease lesions. So to do this talk, I looked at three of the major guidelines used by OB and MFM. And these are the references. And again, just for review, the AIUM recommendations for cardiac imaging is the following. For a standard OB ultrasound, cardiac activity, four-chamber view, the left and right ventricular outflow tracts, the three-vessel view, and the three-vessel trachea view if technically feasible. Now, on a detailed OB ultrasound, they also include situs, aortic arch, the SVC and IVC, ductal arch, neuroventricular septum, the three-vessel view, and the three-vessel trachea view. So we're going to start off today by starting off with the four-chamber view. And there's many things you can see by the four-chamber view and many congenital heart diseases you can pick up. And we'll also show you a few that you will not see, and that's why we add the different views. So the four-chamber. In the four-chamber, as you can see here by this diagram, there's two atria. They're approximately the same size. As gestational age increases, usually the right side of the heart dilates a little bit more than the left. You want to look for the flap of the foramen ovale, which you can see here, which should bow to the left atrium. Also looking for the primum septum, which you can see here at the crux of the heart, and looking for at least one pulmonary, if not two pulmonary veins entering the left atrium. And then moving on to the ventricular chambers, there should be two ventricular chambers approximately equal size. Again, the right should be a little bit bigger later in gestation. And the moderator band sort of denotes the right ventricle, while the left ventricle is more of a smooth ventricle at the apex. Then again, looking at the ventricular septum for any major holes. And looking at the atrial ventricular junction and valves, making sure the crux of the heart, which is seen right here, is intact. And usually the tricuspid valve is a little bit apically displaced compared to the mitral valve. So here's an example of a normal four-chamber. Again, we always look for the spine, which you can see here. So this is left, this is right. And you can see nicely you have a septum that bows correctly to the left. The LV and RV are about the same size, and the tricuspid valve is a little bit apically displaced. So here's a nice example of a normal four-chamber heart. Now moving on to our abnormal examples, we'll first start off what can you diagnose in a four-chamber? So an atrioventricular septal defect, mostly the complete atrioventricular septal defects, single ventricle lesions, hypoplastic left heart syndrome, tricuspid valve atresia, double outlet right ventricle mitral valve atresia, double inlet left ventricle, unbalanced atrioventricular septal defect. Tonight we'll talk about hypoplastic left heart, tricuspid valve atresia, and double inlet left ventricle. Ebstein's anomaly or tricuspid valve dysplasia, and congenitally corrected transposition of the great arteries. So those are the ones that we will review tonight. So a complete atrioventricular septal defect, the anatomy is as follows. There's usually a hole or a primum atrial septal defect and an inlet ventricular septal defect that you can nicely see here in this diagram. And here the atrioventricular valves are one big valve, and they're not separated in a tricuspid and a mitral valve. So those are sort of the caveats of this lesion. It's associated with Down syndrome, and these patients usually are seen 2 to 3 times in fetal clinic and can be born to the newborn nursery or the NICU, depending on the institution. So what do we see by fetal echo? Again, here's the spine. So this is left, this is right. You can see here that there's not much of an atrial septum, and essentially the crux of the heart is completely missing. So that is your tip off that this is a complete atrioventricular septal defect. Your primum septum is above the valve and your inlet VSD is here. You can see that your right ventricle is dilated compared to your left, but overall good function. Here's another 4-chamber view. Again, I think nicely just showing the single AV valve. So you don't have the second leaf or the 2 leaflets here in the tricuspid valve or the mitral valve. There's really just one big valve that opens nicely into both ventricles. Also, when identifying atrioventricular septal defects, looking at the valve en face and the transverse plane is also very helpful. Here you can clearly see that it's one large valve instead of 2 separate valves. So here's the right, here's the pulmonary valve. So here's your tricuspid valve that still looks like a triangle, but unfortunately your mitral valve also looks like a triangle instead of a circle or a fish mouth. So this is a nice way to sort of confirm your diagnosis of a complete atrioventricular septal defect. So how are these patients, once they're identified, what surgeries do they require? So most of these patients are delivered and monitored in cardiology monthly, and around 3 to 6 months of age undergo a complete repair. This can be done multiple ways. Here's an example of a 2-patch technique where they patch the atrial septum, then the ventricular septum, and then they divide the AV valves into 2 AV valves. Again, these patients overall do well. Future surgeries include left ventricular outflow tract obstruction or AV valve repair or replacement. So those are things that these kids are monitored for long term. So this another congenital heart disease that is identified in the 4-chamber view is hypoplastic left heart. So now we're going to sort of review those single ventricles. So
Dr. Johnson.
Uh-huh.
So to let everybody know, it looks like the chat feature may be disabled, but
Okay.
you can use the Q&A feature as well, and I'm seeing those.
Okay, great.
So if you'll use that feature, then we'll be able to answer questions as we go through.
Great. Okay, thank you. So hypoplastic left heart syndrome is a spectrum of left-sided lesions. The left ventricle size, mitral valve stenosis or atresia, aortic valve stenosis or atresia, coarctation, and hypoplastic aortic arch. These patients can be associated with Turner syndrome from a genetic standpoint, and they're usually monitored 2 to 3 times during fetal clinic, and post-delivery will go to the cardiac ICU for management. So here's an example. Again, here's your spine. So this is left, this is right. You can see how big the right atrium and right ventricle are compared to the small left ventricle. You can see that the mitral valve really doesn't have much of a leaflets and pore excursion overall. So this example of hypoplastic left heart syndrome. Here's another example. This example, the LV is so small you really don't see it. It sort of has become the shoulder of the right ventricle. So those are 2 different versions of hypoplastic left heart. The first one is more of a Schoen's complex with a very hypoplastic left ventricle. This one, the ventricle you can barely see. So this is all right ventricle, or yes, all right ventricle. Then moving on, because as we talked about, the ascending aorta is also small and hypoplastic, which you can see here. Comparing it to your right superior vena cava, you can see the significant difference in the ascending aorta and its size. So then again, moving our attention to the aortic arch, I think sometimes these aortic arches are so small, you really don't see them well by 2D. So one of the tricks that I use is put the color box over the PDA or where I think the aortic arch is and look for this reversal of flow. So in this example, you can see that the aortic arch is hypoplastic throughout. And then when you look by color flow mapping, you can see that there's reversal of flow in the transverse arch, making you think there's severe aortic valve stenosis or atresia. So that's another way to sort of look for these arches because they can be very small. And now the other side of the single ventricle is tricuspid valve atresia. So this is where the right side is small and the left side is normal. So this, again, is nicely seen in a 4-chamber view. You can see that you will look for a tricuspid valve that really has no connection between the RA and the RV. The RV can be very hypoplastic. There's a ventricular septal defect between the normal size LV and the small RV. And the great artery relationship can be normal, can be D transposed or L transposed. So here again, looking at your 4-chamber, here's your spine, so you know that's left. So your left atrium, you see one AV valve, which is your mitral valve. And then you can nicely see that your tricuspid valve is completely muscularized. There's really no leaflets. Here's your ventricular septal defect, and here's your small right ventricle. So this is a nice example of tricuspid atresia. And then moving on, now after we've decided that this is tricuspid atresia, we need to figure out the great arteries. So we sweep up anteriorly. We see from the left ventricle, there's a semilunar great artery that doesn't branch. And then when we look at the small RV, we see a semilunar valve that branches. So that's the pulmonary artery. So this is tricuspid atresia with normally related great arteries. And here's just one more example where you can nicely see, here's the left ventricle. There is your aorta because it does not branch by color. And then again, looking nicely by 2D, here's your small RV that branches into your right and PDA. So normally related great arteries with tricuspid atresia. And the third type of single ventricle that we've seen a lot here is double inlet left ventricle. So double inlet left ventricle is again nicely identified in a 4-chamber view. In this lesion, you'll see both AV valves are on the same level and they're connected just to one ventricular chamber. And it's of left ventricular morphology. Then the right chamber can either be left-sided or right-sided. The great artery arrangements can be normal, D malposed, or L malposed. And you look for AV valve stenosis or atresia as well. So here's another fetal example. Again, here's the spine. So this is left, this is right. You see both atrium, and you see that both AV valves sort of drop both into this large or the single ventricle. So this is a good example just in the 4-chamber of a double inlet left ventricle. So just like triatresia, we have to figure out where our great arteries are. So another example of a 4-chamber, we can see here is the left ventricle with both AV valves arising from it. And we can see here that our right ventricle is here on the right side. So now that we've identified where the right ventricle is, we need to work on the great vessels. So in this sweep, you can see as you sweep up, just like in the patient with triatresia, it's normally related great arteries. So you can see here is the small right ventricle, and a pulmonary artery comes out of that right ventricle. So it's normally related great arteries. So what kind of interventions do these single ventricles? So all 3 of these patients at least need stage 2 and stage 3. Most of the patients will, depending on what their aortic valve sizes and arch looks like, will need a stage 1. So these patients, it's a stage palliation, and the goal of these palliations is to get all the blue blood to the right pulmonary artery and use whichever ventricle is the biggest in the heart to use that to pump red blood to the rest of the body. So a Norwood procedure is the first stage. So a Damas Camsel or DKS can be performed by combining the aorta and the pulmonary artery. So that gives you your systemic outflow. Then the aortic arch is repaired via a patch, and then a BT shunt or a Sano shunt are added to give pulmonary blood flow, depending on which surgical hospital you're at, what your surgeon's preferences or the patient's anatomy determines that. Again, a reminder why these patients can get so sick, having an increased risk of mortality, is because the BTT shunt and the Sano shunt are the only source of pulmonary blood flow. So if there's a kink or a clot in either of these patients overall do not do well. This procedure is usually done 7 to 10 days of life, and then they're monitored very closely, either inpatient or outpatient, until the second stage. The second stage of the procedure is called a bidirectional Glenn. At this procedure, it's usually done anywhere from 3 to 6 months of age, depending on the nature of the lesion. So in this stage, we're going to take the right superior vena cava and add it to the right pulmonary artery. So to let all the blue blood from the upper body go into the right pulmonary artery. Again, the SATs will go up to about 85%. This is obviously a bigger, more stable pathway for pulmonary blood flow than just that BTT shunt or Sano. And patients usually go home after 1 to 2 weeks after a Glenn and are followed in clinic every 4 to 6 months. Then anywhere, depending on your institution, from 3 to 6 years of age, a patient will complete their palliative stages with a Fontan pathway. So as you can see here, you can use an extracardiac conduit to connect the blue blood from the lower body via the IVC up to the RPA. Sometimes, depending on the pulmonary pressures, they will require a fenestration or not, just to make sure their pressures are not high in that conduit. Overall survival from all comers of single ventricle is about 60% to adulthood. Some lesions have a higher survival rate than others. It just overall depends if you have any other comorbidities after these procedures. So another one that can be tricky is congenitally corrected transposition of the great arteries. I find this one of the more interesting diagnoses. And I think once you sort of look for the details in the four-chamber, you can really see it. So anatomy-wise, you can see here from this example, the right ventricle's on the right, the left ventricle's on the left. But in congenitally corrected transposition, the ventricles are inverted. So the left ventricle is on the right and the right ventricle is on the left. And unfortunately, because of that, that means the right ventricle, that is usually not built to be the major pumping chamber of the heart, has to pump to the rest of the body and the aorta. And then the LV, which is sort of created to pump against high pressure, only goes to the pulmonary arteries. Genetics, there's usually no specific genetic syndrome that goes along with this. Again, these patients are seen 2 to 3 times in clinic and can go to a cardiac flora or ICU post-delivery. So how do we identify these? So again, making sure we know our left and right. So here's the left. These patients also can have dextrocardia, so you have to make sure you know your situs. So when dealing with corrected transposition, make sure you know which is left and which is right. So this patient has levocardia. So this is left. You can sort of see when you look at the right ventricle, you just don't see that moderator band. It's sort of smooth. You don't really see the moderator band. And you can see that this valve is more apically displaced than this valve. So sort of teeing you off that this could be a tricuspid valve. So now looking at the upright view, I think you can nicely see again, here's your spine. Here is your moderator band that would make it a right ventricle on the left side. And you can see that this right AV valve is apically displaced, more consistent with a tricuspid valve. So this is showing you that your right ventricle and tricuspid valve, because usually the ventricle goes with the AV valve. So if you have a right ventricle, you should have a tricuspid valve connected to it. This is a nice 4-chamber example of corrected transposition. Again, looking at the sagittal view you can see that the left ventricle is more anterior than the right, because that's also another tip off. Here's the spine. So you know this is posterior, this is anterior, and this is a mitral valve. So another way to confirm with your 4-chamber that the ventricles are abnormal. And then another way to look is sort of confirming we know that this is a left ventricle, goes anterior, and the pulmonary valve comes from the anterior ventricle, and we know that the posterior ventricle is a right and the aorta is coming from there. So that's another way to sort of confirm what you're looking for, to make sure you don't have something called detransposition of the great arteries. So a good way to confirm. Congenitally corrected transposition has many surgical options. It's one of those tricky diseases. So a lot of people just opt for monitoring, don't do anything. Some patients have ventricular septal defects and they just have those closed, and they again opt for monitoring, knowing that these patients, because the right ventricle is your major pumping chamber of the heart, these patients may or may not need a heart transplant sometime in their lifetime. Those patients who have decreased RV function due to systemic pressures or a lot of leaking of their tricuspid valve can opt for a double switch, which is pictured here, where the surgeon funnels all the blue blood to the right side of the heart and then funnels the red blood from the pulmonary veins to the left atrium, or the left side or the right side of the heart, to the left ventricle, and then does an arterial switch. So now the aorta is going the left ventricle to the aorta and the right ventricle to the pulmonary artery, in hopes that now, since the RV is pushing against less pressure, that the function will be preserved. Now, Ebstein's anomaly is another really nice lesion that can be picked up in a four-chamber. As you can see here from the pathology specimen, the hallmark of this is the right atrium is very dilated. Even the right ventricle can look dilated as well, and the left ventricle can be very small. You also look at the leaflets and you can see that the septal, which is the leaflet here, is very tethered, and then the leaflet in the back, the inferior leaflet, also is very stuck on to the ventricle. Then depending on the anterior leaflet, that's the one leaflet you really nicely can pick up in a four-chamber. It is very redundant and sail-like, and if you put the color on, you can see that there's usually significant insufficiency. So again, looking for other anomalies besides Ebstein's anomaly, atrial septal defects, ventricular septal defects, RVOT obstruction as a pulmonary stenosis to atresia, PDA, coarctation, and left-sided lesions, also CCTGA, as we talked about before. Genetics, there's usually not a high propensity for genetic syndromes, and again, these patients are seen multiple times during fetal life. So here's an example. Again, this is nicely seen by a four-chamber. Here's the spine over here, and all of this is your right ventricle, and this is all your right atrium. Your left ventricle is a small little thing over here. So these are very nicely seen in the four-chamber. Now, when you put color on the tricuspid valve, you can see that the insufficiency starts lower in the apex and goes all the way to the top of the RA, which would be consistent with severe insufficiency. This is probably one of the most severe Ebstein's cases I have seen. Again, here's your spine. So this is left. So this is your left atrium. This is your left ventricle. This is your atrial septum. And this is your right atrium. So patients that have severe cardiomegaly, as of this patient, usually has poor lung functions. The lungs are not as well developed because of the large size of the heart. So these patients overall in this state do not do well. So procedure-wise, these patients sometimes require single ventricle pathway. A lot of patients, especially the ones that we showed here with the significant RV and RA dilation, sometimes need a palliative procedure until they can get to a tricuspid valve repair called a cone procedure. That is a way to fix these types of valves so these patients can push off something like a tricuspid valve replacement till later in life. So those are all the those are all the four-chamber anatomies, congenital heart disease that we can see. And now the three-vessel view and the three-vessel trachea view, which I think is done very routinely by OB. So the three-vessel view and the three-vessel trachea view. So now we're just looking up higher in the chest, and we're sort of looking for the order of the vessels and the arrangement. So which one's anterior, which one's posterior. So in this arrangement, it looks like, so in a normal arrangement, you have a pulmonary valve that's anterior. It starts first and it's the most left, aorta, and then right S, or usually the right SVC. Again, the size of the pulmonary should be the biggest, then the ascending aorta, then the SVC. So always making sure the pulmonary is the most anterior and the most leftward. So here's an example of a three-vessel view. You can see here, this is left, this is right. The pulmonary valve is here anteriorly, here's the aorta, and here's your SVC. Now looking at the three-vessel view, trachea view, this is a more tilted cranial, and it's going to give you not only your MPA, but your duct and your aorta. And it's going to give your aortic arch sidedness as well. So this is more, I do this more of a sweep. I think OB and MFM do it more as just a moving clip. So here's an example. This is sort of more of a sweep. You can see that the pulmonary valve is anterior, then the aorta, then the SVC, and you can see that the aorta is to the left of the trachea. So it's the left aortic arch. So what congenital heart diseases can you identify with the three-vessel view and three-vessel trachea view? I think the most important is transposition of the great arteries, tetralogy of Fallot, which I think is diagnosed probably the most often with these, truncus arteriosus, and coarctation. So transposition of the great arteries. Transposition of the great arteries is one of those defects where the pulmonary and systemic blood flows are parallel to each other. So here you can see in this pathology example, here is your right ventricle, and connected to your right ventricle is your aorta. So all your blue blood is going to your aorta. And then when you look over here to the left ventricle, you've got your left ventricle connected to your pulmonary artery, which now red already oxygenated blood is going back to the lungs. So you can see there are two separate circulations, and we really need a place for mixing once these patients are born. So for these patients, everything is really dependent on this atrial septal defect and how big it is. So again, parallel circulations need places of mixing. Ductus arteriosus is an okay mixer, but really the most important is the atrial septal defect. You can also have associated lesions of coronary artery abnormalities, ventricular septal defects, and coarctation. So just a reminder that in transposition, the four-chamber looks absolutely beautiful. So if we're looking at this four-chamber, like, oh, normal heart, we're good. Unfortunately, this patient has transposition of the great arteries. Again, here's your spine. So this is left, this is right. This looks like a nice, beautiful four-chamber. Unfortunately, as you sweep up, you can see if you follow the outflow tracks that it isn't so normal. So again, here's your spine. We're going to start in the left ventricle and watch it play. So the first great vessel, we see branches into left and right pulmonary arteries. This is coming from the left ventricle. Now we move our attention to the right, and we see that the semilunar valve does not branch at all and gives rise to an aorta. So this is an example with sweeping of transposition of the great arteries. So how can we identify that in a three-vessel view? So again, like I said, the cardiologists like to do a lot of sweeping. So you can see here, here is your aorta, and it is more anterior and leftward. So we've got not only is the aorta anterior, it's leftward, and the order is aorta pulmonary SVC. So we already know there's a problem. So that's what you can nicely see. And here's a still frame of that. So again, our order is incorrect. So here's just a schematic of that. So your aorta is anterior, it's the most leftward, then you've got your pulmonary, then you've got your SVC. So again, the order and the arrangement are wrong. So this is a good example in the three-vessel view to look for transposition. Again, always confirming with sweeps. So surgical repair. So these patients, as we talked about before, all of their oxygen saturation depend on that atrial septal defect. So these patients, when they are born, if their atrial septal defect is small, their SATs can be 50%. If it's nice and big, they can be 85, 90, 95. So that's why you might have a transposition hanging out in the newborn nursery and not identify them until you do the 24-hour congenital heart disease screen. And then when you see SATs of 90, an echocardiogram can confirm transposition. So these are patients that we'd like to identify since they may need a procedure for a cath procedure, atrial septostomy, prior to going to surgery. So these patients undergo an arterial switch, usually anywhere from 3 to 7 days of life. And the goal of this surgery is the surgeon cuts the great vessels above the sinotubular junction and brings the aorta forward, or brings the pulmonary valve forward with the branch BAs and the aorta backwards. So now the pulmonary is connected to the old aorta and the aorta is connected to the old pulmonary valve. The coronary arteries also have to be translocated as well and placed on the neo-aorta. So these patients overall do well. And there are a few things we have to monitor. So these kids are also monitored lifelong. Tetralogy Fallot, it's another conal truncal abnormality. In this abnormality, you have a large malaligned ventricular septal defect, which you can see here with the aortic valve overriding it. And you've got right ventricular outflow tract obstruction and hypertrophy of the right ventricle. So those are the 4 caveats. Again, genetics-wise, 22q11 syndrome is very common, and these patients are seen 2 to 3 times. Again, sometimes, depending on your hospital, can go to the NICU or cardiac ICU. So again, when we looked at this 4-chamber, it looks pretty normal too. Sometimes you can nicely, in just the 4-chamber, see the hole, so that can be a tip-off that you're dealing with something. But the 4-chamber looks, again, usually normal if it's a shallow VSD, but then as you sweep up, you can really see the difference between the pulmonary valve, the aorta, and the SVC. So the arrangement of the great vessels is correct or is normal, but there's a huge size discrepancy between the pulmonary and the aorta. That's why I think these are very nicely picked up in the 3-vessel view. So here's an example of a 3-vessel view of a patient with tetralogy Fallot. Again, here's left. So the order is the same, pulmonary, aorta, SVC, but there you can see the significant size difference. And that's a really nice tip-off for tetralogy of Fallot. Again, here's the same thing with color. You've got your pulmonary valve that is significantly smaller than your aorta. And then again, because I like my sweeps from the 4-chamber, as you sweep up anterior, you'll see that the aorta there's a hole below the aortic valve and that it overrides both the ventricles. So that's a really nice way to sort of confirm what you're seeing on the 3-vessel view with the 4-chamber. And then again, remember patients with conal truncal diseases like tetralogy Fallot can have a right arch. So here in this 3-vessel view, you can see that the arch goes to the right of the trachea. So good reminder, arch-sidedness, right aortic arches, a big aortic arch that goes to the right, think tetralogy of Fallot. So these patients, again, do well after delivery, depending on where their branch pulmonary arteries or how big or small they are, usually undergo surgery 3 to 5 months of age, sometimes need a palliative step if their branch pulmonary arteries are small or discontinuous. The main surgical repair is done 3 to 5 months. It consists of patch closure of the ventricular septal defect, and then depending on the size of the pulmonary valve, can you do a valve sparing where you leave the pulmonary valve alone, maybe patch above or below it, or if the pulmonary valve is too small, the surgeon patches right through the valve to make the RVOT bigger. These patients, a lot of times, because the pulmonary valve is not as functional as it should be and has a lot of leaking because of the patch that has to be placed across it, will need pulmonary valve replacements around high school and college. So the other one that's nicely diagnosed in the 3-vessel view is another conal truncal lesion called truncus arteriosus. Again, there's a single arterial trunk that comes out of the 4-chamber. This semilunar valve can be bicuspid, tricuspid, or quadricuspid. We usually cannot tell that by fetal echo. That's something we see in pediatric transthoracic. And there's a large ventricular septal defect between the 2 chambers. So again, this is associated with 22q11. These patients are seen 2 to 3 times and go to the cardiac ICU after delivery. So here you can see, again, the 4-chamber looks great. really liking it. And then we sweep up and you're like, ooh, what is this big vessel here? And you don't see a pulmonary. So you're like, oh, I just see one vessel. I see a hole between the bottom chambers and one big vessel. Truncus arteriosus is very high on my list. So now as we come up to our 3-vessel view, we can see that we have one semilunar valve and we have, it looks like a branch coming off that semilunar valve. So it looks like we have an arch and then one branch. Again, when you're dealing with truncus arteriosus, there's many different types. So finding the left and right branch pulmonary arteries is important. Here in the still frame, you can nicely see here's the truncal valve and here's the arch. And then this is a right pulmonary artery. So now, again, sweeping high in your 3-vessel view, you can see sort of the thickened truncal valve, and you see both the left and the right. So this is the left, this is the right branch pulmonary arteries, and here's the aorta. So it's a nice example of a truncus arteriosus. These patients usually undergo surgery the first 10 days of life. Surgery is usually not waited on as long as they're appropriate size and gestation because they can rapidly get pulmonary hypertension. So surgery consists of closing the ventricular septal defect. And since you don't have a pulmonary artery, an RV to PA conduit is placed and both the branch pulmonary arteries are removed from the aorta and placed together. These patients overall do well. Obviously, the conduit does need to be replaced throughout their lifetime. So these patients need to be followed continuously through cardiology for conduit replacements. And now our last view that I think is also important is the RVOT and LVOT tracts. So again, looking at your 4-chamber and then tilting anterior to get to the aorta, you nicely can see the valve, get the diameter of the aortic valve, look for ventricular septal defects when looking at the LVOT. Here's an example of that. You can see here's the aorta, here's the ventricular septum, and you nicely see no holes. So this is a normal, the leaflets look thin. So a normal LVOT, and then RVOT is sort of close to the parasternal short that we see in pediatrics, pediatric transthoracic. You're going to see the RA, the tricuspid valve, the RV, and the pulmonary valve and its branches. So here's an example of a normal RVOT tract, pulmonary, RPA, and this is probably PDA. So what can we see? So the biggest important things are aortic valve atresia, stenosis, because these can be progressive lesions, pulmonary valve atresia, stenosis, transmission of the great arteries, which we already reviewed. So pulmonary stenosis, so we're looking for a thickened doming pulmonary valve, can have insufficiency, can have a gradient with Doppler. These patients are seen 2 to 3 times, and depending on how high their gradient is, can go to the NICU or cardiac ICU, possibly needing intervention prior to going home. So here's an example. You can see here's your right ventricle. And right off the back, when you look at the pulmonary valve, it's not opening parallel to each other. It's sort of making a V. So you can easily tell that there's this valve is not right. So then we put color on our valve, and you can see from the red that it's leaking, and you can see all the color flow aliasing. Then by Doppler, this patient is 32 weeks of gestation with a velocity of 3.4. Usually velocities of the pulmonary aortic valve, the highest velocity is 1.4 would be within normal limits. Anything above 1.4, closer to term, would be greater than the 97th percentile. So this is easily significant pulmonary stenosis. So what do these patients go, what happens to these patients after delivery? Well, depending on how high their gradient is in the 3rd trimester, most patients with velocities greater than 3 meters per second will undergo a cardiac cath balloon valvuloplasty, which is seen here in this diagram. Those patients whose velocity between 2 and 3 can sometimes go home and come back in the first 1 to 2 months of age for their pulmonary balloon valvuloplasty. In rare cases, the stenosis is so bad that cardiac cath is unable to relieve the stenosis, so a transannular patch or surgical intervention is required. And the last one we have is the aortic valve stenosis, very similar. This time you're lifting up to the LVOT tract. You're looking for a thickened doming valves, insufficiency, stenosis. These patients sometimes need extensive monitoring depending on what the left ventricle looks like. If it's thickened, so these patients can sometimes be even seen weekly, just depending on how bad the stenosis is. So here's a nice example. Here's the same LVOT track that we looked before. You can see through colorful mapping that it accelerates as it goes past the valve. And then here, when you look at this velocity, it's 2.1. So this is a patient, they are 30 weeks of gestation, so they're above the 97th percentile for velocity. So this would be a patient that we definitely would get an echocardiogram post-delivery. And the other scary thing about aortic valve stenosis is that it can be rapidly progressive. Even as a newborn infant, it can progress within a few weeks. So we always have to keep an eye on there. So this is a more mild form of aortic stenosis compared to this patient. As you can see here, you've already looked at the LV. You can see that the LV is very calcified, has EFE, and is very dysfunctional. And when you look at the inflow through the aortic valve, it's very small. When you put a Doppler through it, the velocity is very high. This is another example of a similar patient. This patient has severe aortic valve stenosis. The valve minimally opens, as you can see here, and because of all the stenosis, that the LV has become very dilated and dysfunctional. So these are sort of the gradual stages of aortic valve stenosis and the spectrum of it. You can have mild, like the first case we saw where the LV was normal size and normal function, to these last two patients. When you have severe aortic stenosis where your LV is dysfunctional, like in both of these cases, usually these patients undergo a single ventricle palliation. So AS can be dealt with like in the cath lab with a balloon valvuloplasty, surgically through an aortic valveotomy. And some patients, the aortic valve is not usable, so they undergo a Ross procedure, which is shown here, where the pulmonary valve is moved to the aortic position and an RV to PA conduit is placed. And just like the last two examples we gave you, these patients may need to go under the single ventricle pathway like we described before. So I think those are all our cases. Thank you again for coming. We'll take questions. Just a reminder that we'll be doing this monthly. October 19th at 5 p.m., we will do transposition of the great arteries. And this is the HCA CME slide.